Hello, my name is John Christoforetti. I'm an orthopedic surgeon in Frisco and Allen, Texas, and I'm the director for the Texas Health Resources Center for the Athlete's Hip. I want to thank the Southwest Athletic Trainers Association and course organizers for inviting me to discuss the cutting edge of athletic hip injury management, modern reasons for surgery in the athlete's hip. I hope you enjoyed this video reel remotely, and I can't wait to see you all up in Frisco and Allen in the years to come as this pandemic finally ends. These are my disclosures, although they are not directly related to the nature of creation of this talk. I am on the Executive Board of Directors and the General Secretary for the International Society for Hip Arthroscopic Surgery, as well as serving as a consultant and designer for various hip surgical and arthroscopic instruments and bracing products. Okay, so the topic for today is that's been assigned to me by the conference organizers is the cutting edge in athletic hip surgery, and I'm hopeful that through participation in this short lecture, you'll find yourselves updated on what things we're doing on the doctoring side that help support all your excellent efforts on the field. I'm going to try my best to make this more conversational, considering I'm sure we're all missing getting together in person. And I'm going to include a few video segments, and we're going to jump around just a little bit, but hopefully this helps everybody stay focused on some new stuff here in our offices here in Frisco on the grounds of Toyota Stadium. We're routinely working with trainers from around the country, and it is really an excellent opportunity that the Southwestern Athletic Training Association has really given us to come and get together and talk about the hip. And what we normally find is that people are really very comfortable knowing what the surgeons are doing. What do I do if I'm doing shoulder repairs or knee repairs? I think many trainers have really heard about this, and they may have even come and observed surgeries for labrum repairs in the shoulder, or even ACL surgeries or meniscus surgeries in the knee. But the question really is, have they ever had that exposure, that same balanced exposure to surgery and surgical techniques within the athlete's hip? And most often around the country, what I hear is, no, we're not getting that same amount of exposure. So when I received this invitation, I was very excited to accept it and hopefully share with you some really inside information about how we take care of athletes once all the conservative measures have failed and what's gone on. Now, before we get to the surgery videos and the actual techniques that we use, and I want to give you a great survey of those, I'd like to start with just a short introduction to how we want to group evaluation for possibly surgical injuries in the hip. And you've already got these mechanisms in the shoulder and in the knee, and maybe we could just review these very, very quickly. So I really want to have us focus today on three areas that we can, as athletic trainers or as covering team physicians, that we can really keep in the back of our heads about when might an athlete have a potential surgical indication in the hip. Now, the first, of course, is in trauma or collisions or falls, where we see acute, meaning right all at once after the injury, they've fallen down, they can't stand up, and that can, of course, be divided into both a contact type of injury, where there's been player on player or player on ground or player against obstacle collisions, or you can have non-contact traumas where they're just accelerating or cutting or pivoting, and all of a sudden they can't walk. They're reaching to that area, that hip area that's bothering them, and this is an acute setting where we might be thinking of what do we do and how do we help. And we're going to have some more training coming out later on in the year about how we do this on-field and management, and it's a little bit beyond the scope of this talk, but suffice it to say that the first category we need to think about what what might be surgical, of course, is trauma and trauma-related things that really result in a player taking that C sign and pointing it at the hip joint and telling us that they really just can't get up, they can't walk, and we have to assist them off the field in one way or another. We know that those players are very likely going to need imaging, and they're very likely going to need a surgical evaluation if they simply can't ambulate. And the most common reason for that, of course, is going to be fractures about the hip or acute tears of the tendons or muscles of the hip. And then the third one may be some injury inside the joint of the hip. And inside the joint of the hip, of course, we have the articular cartilage of the ball and socket, and that's the weight-bearing cartilage on the ends of the bones. And we, of course, have the seal cartilage, and that's the labrum cartilage. And we're going to get into some of that later in this lecture. And I hope that that's going to be well explained with some models here later in a different portion of the lecture. But let's just review that the first thing that we want to think about when we're dealing with that surgical category of hip injury, it's going to be that player that's had some type of on-field trauma, contact or non-contact, has an inability to walk or ambulate normally without a limp, and they're really gesturing to that region that we would define that region as that hip region. And once we've got that player identified, we're really thinking along the lines of anatomical structures. We're thinking about, okay, what about fractures about the hip or pelvis? What about tears of the muscles or tendons? And what about the joint itself? Could it possibly have subluxated, meaning partially dislocated, or completely dislocated? When that happened, could have been associated with a fracture. These are questions that we're going to have. Then we're going to get into that second category of hip that we maybe want to be a little bit less common for us to be able to identify on the sideline during the game, but we're really not talking about chronic training related or practice related non-traumatic complaints about the hip. And these might be grouped into categories like anterior hip pain, C-sign hip pain, lateral hip pain, or posterior hip pain. And we really have to make sure that we're really cautious about what we group into these areas. But I want to make sure that we're also remembering that, whereas in the shoulder and in the knee, many indications for surgery are really only in category 1, which are those traumatic injuries to the bones, to the joints, to the muscles or tendons. But in the hip itself, many more commonly, we will see patients presenting to the athletic trainer with chronic trouble either in the lateral hip or in the deep anterior hip or deep in the center of their hip or in the posterior hip. And in this area, we're going to be thinking about after training, after lifting, after running. And of course, when we get into these areas, we're talking classically about overuse diagnoses, where we might think about stress fractures, tendinitis. We all have heard about iliotibial band syndrome or IT band syndrome. But what I wonder is, have you had an opportunity to learn much about what about the developmental underlying musculoskeletal structure of your athletes? Most of us, if we don't have an x-ray available, we may not have a chance to really have an understanding of whether or not they were born with a normally shaped hip or an abnormally shaped hip. But what we can do is get a sense for whether this hip has a normal athletic range of motion or an excessive athletic range of motion or a limited athletic range of motion. And what I'm getting at in this is, remember, category 1, traumatic. Category 2 is chronic during the course of the activity of their sport or training for their sport without trauma, without the inability to all of a sudden they can't walk, and they're coming to you and they're talking about pains in the outer hip, pains in the front of the hip, pain in the posterior hip. So we're really in that area of category 1, trauma. Category 2, we're talking about athletic related complaints in the hip area. And we're talking about opening our minds to the same anatomy that we were thinking about in the trauma zone: bones, muscles and tendons, ligaments, cartilage structures. But we're also talking about thinking a little bit deeper than that and taking a listen and taking a look, taking a listen to what the coaching staff or the players' sporting activity are asking from the hip. What range of motion, what speed, what acceleration, how regularly they're asking it, and then taking a look at that patient's hip range of motion and making a decision. Boy, it sounds like this is a sport that requires a lot of hip motion, but this player has very little. Or it looks like this player has a lot of motion and he or she continues to put a lot of load on themselves. Maybe that load is exceeding the stability of that joint. And what I'm getting at is that when we get to that category 2 surgical indication diagnosis, we're talking about players that have had injuries in structures that have been injured due to misfits between the activity they perform, the structure of the hip that they were born and developed into, and then unfortunately some bad luck as it relates to the endurance of those tissues that may not be tolerating that well. Most commonly, our surgical indications are going to be in the area of cartilage repair of the hip socket, tendon repair of the outer abductor complex, tendon repair to the hamstring complex. But we have some even deeper abilities in surgery these days, and those surgeries that we do that are the most important in athletic hip injury, they're the ones that identify those athletes that take their birth structure and they change that birth structure to allow it to better fit the sport that or activity that they've selected. And I'll give you some examples as we go through and we get on that whiteboard. I'm going to show you with the model, but I wanted to just start here where it all begins for you. This is in the kinetics area of our office. We're really evaluating movement patterns of athletes. Now, in our office, we have the advantage of x-rays and we have the advantage of MRI scans, which we know in the training room we don't have the advantage of that, and we're looking to really get more information in your hands so that you know, hey, wait a minute, what about this player says it's different than just muscle ache, muscle pain, or things that we can treat excellently with our training modalities, whether it be any of the modalities, icing, heating, dry needling, all of the things that work in the soft tissues. One of the things I wanted to jog with your category 2 surgical indication is sometimes if you're having to put a ton of work into a player's soft tissues, and one week it's the lateral hip, and 1 week it's the anterior hip, the next week it's the buttock, and you just can't seem to figure out why it is, like you're chasing your tail with them. Many times these athletes are athletes that have a conflict between the skeletal motion of their hip and the sport or training, more importantly, the training requirements of the hip. And I'm going to give you some brief examples about that as we look at some of the surgeries in category 2, which is that chronic migratory, meaning one place today, one place tomorrow, athlete that's just not able to train, not able to go because after their activity they're having a real hard time with hip-related discomfort, and those are players that you want to trigger for first x-ray evaluation and then potentially more advanced evaluations. But in your own hands, what you can do is really think now, boy, that category 2 athlete, that athlete that I don't really know what happened to them, but she keeps coming in or he keeps coming in telling us about areas of the hip that hurt. Now you know that there are actually surgeries out there that if in fact in the most extreme cases the player has injured something and that's why they're not getting better in your hands, or in the more common case they've actually just chronically irritated or chronically worn the cartilages or tendons of their hip as a result of a conflict between the structure they were born with and the sport or training they're doing. You know, then you've got an opportunity really to know that, hey, just like we reconstruct ACL surgery, ligaments, we repair ACLs, we do all sorts of things. We know that. We're getting those into the surgeon. Now we know maybe you're not stuck having to manage ongoing disabling hip pain for athletes throughout season after season, because you know there are actually things that we can do and evidence that supports those surgical techniques. And we're going to go through some of those in the remainder of the time allotted, but we've really wanted to start more conversational as if we're actually in person, and we'll put some segments to this lecture in video form. We're going to have you join me in the operating room. We're going to have a look at a patient, a typical athletic running patient. We're going to share her story and share her imaging and share where she went, and that's going to be something that we'll cover here in the second part of the lecture. I also want to give you that final third indication where we do see surgeries happening in the hip, and these are indications that are much more rare, but they have to be mentioned. And these indications are things that are really more medical indications that lead to joint-related or bone-related problems in young people, and this is going to be something always in the back of our minds. We're dealing with hip or limping patients or trouble in that hip and groin area, and these are surgical indications that may be, again, about the hip. Things like avascular necrosis, where the blood supply to the ball is not going well and the hip bone is beginning to have not enough oxygen and potentially causing bone death. These are things that cannot be really adequately detected on examination. Things like tumors, things like infections, infectious disease. We see commonly every season we'll see a player that has done, the trainers have done a great job and they're working with them, and then all of a sudden they note the player's having fevers. They get them over, and what we realize is, boy, that was actually an infection in the hip joint, and those are surgical indications to get that infection out of the joint. So I think that hopefully this is, although it's not PowerPoint, hopefully this is something that sits well with you, that we've gone through this a little bit more of a conversation, more of an actual traditional lecture like we might do if you came on an observership or you came to learn, where I'm trying to help you guys understand as best that I can how have I grouped for previous groups awareness for those of you that are in the front lines, really taking care of the athletes, really living with them and what they're doing. We've used trauma, chronic conflicts between the training and sport demands without trauma that lead to lateral, anterior, posterior pain, and then metabolic or medical conditions like infection, tumors, or avascular necrosis, where we have medical reasons that are really unrelated to the mechanical environment, but directly related to the patient's medical condition. So this is the overview section of where we might get our surgeries from. And hopefully by doing this in less than 15 minutes, it's given us some time where you still have some attention span. And I want to show you some of the stuff that you might see on an observership, or if you tuned into one of our live surgeries visually, so you can really see what's it look like when we arthroscopically repair some of the tissues of the hip. Before we get there, I'm gonna bring out the hip model. We're gonna take a break to the whiteboard room, and I'm gonna go over some of these tissues, these tissue areas, and some of the basic concepts using just a few PowerPoint slides, and then we'll shift into some observation of the actual surgeries themselves. So we're gonna go ahead and proceed to the next part of the lecture. All right, so now we're going to go right to a little more standard appearance. We can get some better drawings than we're about to do on the whiteboard. And we're going to talk just about the basic bone anatomy and cartilage anatomy of the hip while we get ready to really unify those concepts of 3 reasons for surgery that we just learned about. So in the healthy hip joint, remember that the pelvis makes up the socket portion of the hip joint, and the femur bone or thigh bone makes up the ball portion of the bone. And on the ends of the bones, both at the socket side or the acetabulum and at the femur side or the femoral head, there is a cushion cartilage called hyaline cartilage that cushions the joints. And the rim of the socket has a fibrocartilage band called the labrum of the hip. And there are some differences between the labrum in the hip and the labrum in the shoulder. And there are some differences between the labrums of both the hip and the shoulder and the meniscus of the knee. But it is definitely very common for your athletes, or maybe even in your basic education you may have received, to really start to compare these fibrocartilage structures because they're a different type of cartilage. Now I'm going to put this into your mind along with the idea that category 1 injuries that we're talking about for surgery are these traumatic types of injuries. And with those traumas, they're largely fractures or dislocations to the bones. And we're really not going to focus in this lecture on the modern surgical treatment of hip fracture. We're going to go into that category 2 a little bit more distinctly, however, and you're going to see that on the whiteboard, but I also want to just give you a little preview with these slides that when we're really talking about category 2, we're talking about these chronic mismatches, and I want to give you the best possible understanding of what that might mean in your athlete's hip visually, and understanding that both developmental changes in the femur and on the acetabulum or on the pelvic side, they can combine to form the changes that we're talking about with bony structural injuries. So this is a schematic that we really love, and it demonstrates the 3 overlapping concepts in understanding that second layer, that second level of surgical indications, and that's when we see that there's a conflict between the functional demand that the sport requires, the mechanical structure of the femur and acetabulum, and even into the spinal structures, and then the patient's inherent genetic biomaterial. That means how tough are their tissues to withstand the conflicts created by their development and the demands of their sport. These conflicts of motion are known as femoroacetabular impingement or femoropelvic impingements. And what we're looking to understand inside these conflicts is what tissues, whether they're tendinous, cartilaginous, or soft tissue structures that are simply connective between those, like the capsule or ligamentous structures, are damaged by the impingements that occur between the femur and the acetabulum. And that can be in the form of ischiofemoral impingement. It can be in the form of what's called subspinal impingement. And it can be in the form of what's called trochanteric pelvic impingement. But the most common type of conflict is in what's termed femoroacetabular impingement, or those conflicts between the ball itself and the socket itself. And when we see those conflicts are most commonly present in athletes that have been very active, and it causes a misshapen femur bone. We're going to take a pause and leave you thinking about some of those concepts as we move back to the whiteboard and keep pressing forward with our 3 categories and the 3 reasons we might be able to group why would an athlete end up potentially in surgery about the hip in 2021. All right, we're going to move in this section of the lecture to really try to clarify some of those concepts and reinforce the concepts in the first portion of the lecture. We're going to be right here in our conference room where we do most of our teleconferencing so that you can feel right at home and join us as we normally do. So what I'm going to review here is that we have three categories. You'll recall we talked about trauma, we talked about chronic overuse or conflict-related injuries, and we talked about metabolic injuries or medical injuries. And one of those things that is like most important, I think, to drive home is that the traumatic and the medical or metabolic are definitely the most important referrals, so that you can be certain to get the right imaging and be certain to make sure that that patient that you're dealing with in the area of athletic hip injury is managed appropriately and really screened with the right x-rays, so that you're not left with a patient that needed to be fixed that wasn't. So I'm going to just start with trauma, and we're gonna hear some overview here. So when we look at the fracture about the hip and pelvis, one of the things to remember is that the most common thing for athletes is really going to be dealing with avulsion fractures, where a muscle pulls against its origin, and it may be pulling off some piece of bone or some other item of bone. Now, rarely are these injuries surgical, but they do need to be considered for surgery. Most importantly, in the areas of the proximal hamstrings, where in an immature athlete, we can see the bone be pulled off and heal incompletely, or in a mature athlete, where we may see the tendon itself pull off, and that's an actual indication for surgery. We'll show you some of those techniques in this lecture. The other areas, of course, that are very serious are fractures across the femoral neck, intertrochanteric fractures, or when the hip fractures out of the ball and socket, we may deal with a fracture dislocation involving the femoral head itself or the rim of the acetabular socket. And these are very common as it relates to athletic injury and fracture for football, for hockey, for lacrosse, and occasionally for soccer. And these are things that you've all potentially been involved with, but recognizing that on acutely on the field that this could potentially be happening, and then these are areas of surgery. These areas of fracture fixation and surgery are not areas we'll focus on today, because I think that these areas have been well described and are well within the experience and acumen of experience of most of our trainers. We're going to go on to the second category. I'm going to talk about these chronic or overuse or conflict related, and that may be confusing because trauma, wait a minute, is about contact. This is conflict. And what we're talking about is the difference between the available range of motion for the patient and the demand of the sport. And we can see things arise in those red zones where we're going to just draw it in as if the sport itself is requiring motion, and the sport itself requires that motion such that the sport needs this much motion, but the patient's hip only gives it this much motion. So to get the job done, they've got a red zone. As that hip is forced into areas where it's not supposed to go, and that can lead to structural damage. Overuse injuries are commonly put into those areas. We may be talking about stress fractures, or whether we're talking about the hip labrum and the cartilage tears associated with the socket, or the deep ligament of the hip, the ligamentum teres. These are areas that can require surgical repair. They don't all for certain require surgical repair, but it is something that inside that conflict zone where that patient is red zoning and they're trying to squat deep, but they really only have so much rotatory motion. I'm going to show you that on the three-dimensional model here. And they just can't. And they may lead to overuse troubles, injuries to those red zoning tissues like labrum tears, or in the outer hip, like the abductor of the hip, the glute insertions can be torn, and when those glute insertions are torn, we do have surgery and biologics that are available at this point that I think are beyond the level of the primary medical doctor in the area of specialty care, either primary care sports medicine or surgery like what we do, to repair things if all else fails. But we want to be aware that in these areas of overuse, we can actually have tissue injury, not just muscle spasm, not just tight IT bands, but we may have deep tissue injury. Just imagine if every shoulder patient only ever had bursitis. We know there's such things as rotator cuff tendon tears in the shoulder. We know there's such things as deep labral tears in the shoulder, that although rehab works for most of those conditions, there's going to be a small percentage that do need to have surgical repair and then rehab and then good training services in order to do what they need to do. But just keeping this in your bag of tricks, that the proximal hamstrings tendon repair, the abductor tendon tear repair, the trochanteric bursal area, And the labrum, cartilage, and ligamentum teres areas deep in the hip are areas that inside these conflict zone that can be repaired. And then we're going to go to category 3. Just looking at category 3, we can see that medical causes like avascular necrosis, like infection that needs to be washed out of the joint, or of course tumors, God forbid, inside our athletes are possible, they're present. And so these are areas where we can apply surgery. And if we go down the list, we can actually see that arthroscopic surgery is possible in not all, but some cases of avascular necrosis, of infection, synovial or cartilage tumors like synovial chondromatosis, where the lining of the joint produces extra cartilage, free bodies in the hip. These can all be treated arthroscopically and with good evidential support. Stress fractures at times can be stabilized. These can be done under arthroscopic guidance. Labrum cartilage tears and tears of the ligament teres can be repaired and even rebuilt with new tissues, and we'll show some of those. Of course, the abductor tears can be arthroscopically, and the proximal hamstring can be arthroscopically addressed for athletes to minimize the damage of the surgery itself. But the most important thing is that we're understanding the tissues. Now, that's a good, hopefully a different kind of summary, something that's a little bit, hopefully a little bit less standard than a PowerPoint. And it brings you into the coaching room where we can really look at some of these areas and reinforce these concepts of where might surgery come into play for you as you're going through your athletic training practice. And I think the most important thing to do is remember that over the last several years, meaning about 10 years, we've had a tremendous growth in this area internationally. And what was true yesterday or even 5 years ago may not be true today as it relates to the limitations of surgery, the return after surgery, the protocol surrounding surgery. But we are starting to get 5 and 10 year results on many of these procedures. So I want to pause there, and then we're going to go and take a look with the model and off the whiteboard to really take a look at some narration about and even onto some slides. I'm going to be introducing the concept of hip impingement, the concept of hip dysplasia, and the concept of correction of hip impingement and dysplasia between open and arthroscopic surgery. And then we're going to go into looking at tendon repair and labrum repair in the hip, just to get you in the operating room and have some fun showing you some of the techniques out there and some patient information. So hopefully, again, the whiteboard session part of this lecture is useful to you as we really outline our differential diagnosis in 3 categories: traumatic, chronic overuse or conflict related, and again, that's where your impingements, your dysplasias, and the damaged tissues in those red zones where those joints are being overloaded by their sports exist. And then finally, that third category, that medical category, where we always have to keep that in the back of our mind about players with limbs. Those are those areas that we have to be very cautious with. So our next step of the lecture, we're going to be transitioning over and we're going to be talking about the concepts of impingement, the concept of dysplasia, and then the concept of correction of these items surgically. Briefly, since I know that's not exactly what you all are going to be tasked with by your jobs, but I do think it's really important, really helpful for you to get a good sense all the way in so that you can really see those players when they're ready and when they come back. Okay, well, hopefully that whiteboard talk broke up the monotony of the PowerPoint, and we're going to go back to some slides. Just going to remind you again that the thought process for that second category of surgical indications, the process where the trainer is evaluating to see if that patient, that player, has a conflict between the functional demand of their sport, the mechanical structure, and have they broken down any of their soft tissues, and can we get at that and correct that either surgery or functionally. This lets us know that when we're actually evaluating our athletes these days for surgery, we're searching for 2 things. We're searching for the pain generator, meaning the thing that hurts them today, their IT band, their abductor tendon, their hip flexor, their glutes, whatever it might be. And we're also really imagining and searching for that conflict that led to today's injury and is going to shape that outcome of that joint, potentially even meaning that patient is going to be at a higher incidence of arthritis in the versions of structural deformity referring to shallow sockets or hip dysplasia or impingement, like we talked about in the red zoning tissues. And so when we're looking at our diagnostic workups, there's certainly no message here that everybody that's got injured tissues needs surgery or that people with pain all have injured tissues. However, we're talking about that repetitive, problematic area for that athlete that you need to get some of that bump up for to get some better diagnostics and make certain that we're not missing anything. These are the concepts of hip preserving surgery that we can take care of. And if you look at the images off to the side of the slide, what you'll learn is that there are excessive areas of bone in hip impingement, like we saw in the moving model earlier, where with arthroscopic or rarely open surgeries, we can remove those overgrowths of bone and protect the cartilage of the hip joint. The thought is that potentially not only will this help the athlete have a more durable repair, but potentially this could delay any adult arthritis of the hip that might lead to hip replacement. There's definitely no information available that would let us believe that just because someone has bones that aren't shaped right, they need to be whisked off and had surgery. In addition, there's no information that just because an athlete has impingement or even a labral tear, if they have no symptoms, that they shouldn't be allowed to progress through to the collegiate or professional ranks. These are just things that we need to take into consideration for the symptomatic athlete, the athlete that has trouble. This is a slide that is super confusing, but I wanted to just introduce you to it and take a look at the idea of what would our associate Dr. Wells over at UT Southwestern, what does he do when we see severe bone deformities like severe femoral twists called anteversion or retroversion? Or what about when the socket is just too shallow like pictured in the gray images? Well, these are operations that can be done to rechange those pediatric or that childhood deformity to provide the bony socket some coverage and support, protect that cartilage, and or to derotate the femur, to realign the gait with the athletic maneuvers. These are surgeries that are definitely very, very powerful for the right athletes, and these athletes may well be identified by the hypermobility of their joints or potentially by the way that their foot points too far in or too far out, in-toeing or out-toeing during the course of walking or athletic exercise. So this is something, again, that we're not going to do a great deal of detail on because these are definitely more extreme variations of surgery. They're open surgeries, and we're going to focus today mostly on the update through the arthroscopic repair of damaged tissues that are resulting in the setting of sport. And this is a video that we can watch together that demonstrates at the cadaver level, what's it look like when we have a cam bump or a bump in that purple area you see, that where that ball goes in the socket, the ball is not perfectly round, and as that athlete goes into a flexion, adduction, internal rotation, or that failure position, you can see that there's been damage to the surface of that socket. And as that hip bump has flexed in, that's been the very cause of that damage. And that is actually hip impingement. And we can see the soft tissues in the front and superior top aspect of that joint that are routinely damaged and sometimes very much silently throughout several years of athletic participation. And it's only right when that labrum tears or that cartilage seen on the inside is damaged that we really recognize the athlete isn't able to perform. So when we get to arthroscopic or endoscopic surgeries, which are definitely surgeries with much more evidence about return to sport that we mentioned in the chalk talk or that whiteboard talk, we can see the procedures that are available currently include debridement of the labrum, repair of the labrum, rebuilding of the labrum with the graft, treating that cartilage defect of the socket or the femur, dealing with the ligamentum teres, that soft tissue ligament that goes between the ball and the socket. These have all been described, and we have experience with all of these, and in our MASH or multi-center arthroscopic study group of the hip, we've published on the outcomes for many of these procedures with several other high-volume centers. But what also about the soft tissues of the muscle tendon units? And those can be the glute tendons in chronic running or the senior masters athlete, or they can be in repair of the proximal hamstrings. I think that this is a great overview, and for this lecture, what we'd like for you to do is just keep this in mind. If anything inspires you to read more about this, there'll be some literature that's always available to research some of these key terms in the surgical arena. Once we move forward from this particular slide, we're going to move through a series of video presentations about the actual process of surgery so that you get a sense of visiting with us without having to travel. So let's talk about the MRI with a labrum tear present. And this is something athletic trainers are definitely going to face. What I'm showing you here is a cross-section of the acetabular labrum with arrows pointing to the two surfaces of that labrum, the labrum being that beak of soft cartilage tissue at the rim of the socket. You've seen that in the cadaver now. The bottom picture is a still image of that surface cartilage tearing away from the labrum, which is very typical in CAM femoroacetabular impingement. The top shows that tear through that labral, what's called labral base tissue.
We need you to know that MRI signal changes are highly prevalent in athletes and frequently misinterpreted as tears. So just because someone gets an MRI and it says labrum tear certainly does not mean that someone needs to rush in and do surgery for that athlete. There's a very important role for history and physical, and many, many athletes can play just fine for long careers with MRIs that show labrum tear. Surgical treatment is definitely a last resort. And one of the things that's real important for you to help your athletes understand is it just really isn't possible for the human brain to discern the difference between the pain from a labrum tear or the pain from a hip deep flexor or the pain just from an inflamed hip. These are things that require imaging, and they require sometimes, if not always, diagnostic numbing injections for us to really understand where is that pain coming from. I do think that it's reasonable to leave a talk on modern athletic hip surgery, which is largely going to be using techniques to reshape the joint and repair the labrum of the hip or reconstruct the labrum of the hip, for me to make sure that I give you a good reference from the Bone and Joint Journal to let you understand what does the labrum do. It reinforces the acetabular rim. That means it makes it deeper and more solid containing of the ball. It contributes to stability at the extremes of motion, particularly for our flexibility athletes. And it really acts as a suction seal gasket to keep that central athletic pivot of the body working throughout sporting maneuvers. So what about some technical stuff for you? We're going to get into doing some virtual surgery here so you get a chance to visit us in the operating room. And I want you just to know that hip arthroscopic surgery, although it is very safe, we're going to learn a little bit about it and learn a little bit about how and why we train surgeons extra specially in order to be able to do these surgeries. And that's because the hip is deep. Bone and ball and socket. There's a lot of big vessels and nerves that go around this joint, and getting access to that joint in that deeply stable configuration requires a lot of skill and a lot of practice. And we've been teaching courses like this for surgeons now for over a decade, and there is good availability of care in most areas of the United States of America. But indeed, we've learned some things about how many times does it take for surgeons to get after things before we're pretty predictable like we are shoulder and the knee. And back in 2017, we learned from some very, very good studies from the New York City area that shows that there's what's called a learning curve to the performance of these operations, and they really belong in specialty hands. We see that surgeons with less than 102 cases a year have a much higher 90-day readmission. That means back to the operating room, back to the hospital for problems, than those that do more of these procedures. And we also see that the results, the lasting results of surgery after these repairs are much more productive for the patients if the surgeon performing the procedure has done at least 340 career cases. So this does not mean that just because a surgeon in your area has done less than 340 cases, there's definitely going to be problems. However, it just lets us know that this is a higher level of surgical technical skill that's required, and just makes it very important, especially for active athletes, that they have full understanding of the experience level of the surgical team, and there are plenty of those available, and absolutely they can feel confident moving forward if a board certified orthopedic surgeon has expressed an interest in treating them. Okay, so we've gone through the overview, and now it's time to talk about expectations. What do we tell our athletes if they've met with a surgeon and that surgeon has good experience with what they're doing and they've told them they need to have arthroscopic hip surgery, and what about return to sport? Well, every athlete varies, but definitely we have good evidence in multiple sports that about an 80, 85, or even higher % returns within 2 years certainly, and usually within 6 to 12 months after arthroscopic impingement correction labral tear is expected in expert hands. Now, if there's higher grades of cartilage damage or other severe bone deformities like the dysplasia, that shallow socket where those soft tissues are overloaded, these numbers can certainly be lower. There have been some variable reports about younger patients, and particularly young female patients with both loose joints and shallow sockets having harder times with return to sport after injuries that have kept them out and required surgery. There are better chances if hip impingement is corrected, meaning the bone is reshaped, if the labrum is preserved and not cut away, or rebuilt back with a graft if it has been cut away, and if the ligament stability is not violated by the surgical team, or if it has had to be violated, if it's been repaired. And of course, the proper rehabilitation protocols and following those protocols and listening to the directions is very important for athletes to get the best possible outcome. Unlike an ACL surgery or a knee replacement, many times the rehabilitation strategy for trainers and therapists can look slow or like it's not doing enough or enough exercise in the early periods, requires a patient approach, and that's a separate talk, but there's definitely an art form to knowing exactly how to counsel and physically rehabilitate athletes back after these surgeries. So now we're going to take some trips to the operating room, and this talk is going to go into a series of cases. We're going to look at setting up the surgery. We're going to look at a labral repair case in the runner. That's another short couple-minute video that will take you through her story and her words, and then into some evidence and some video from the repair, followed by her outcome. And we'll talk briefly about hamstrings repair and glute tendon repairs. But the nice part about a remote lecture is that if you really don't have time to get through that and you don't want to watch any of those cases, you can breeze ahead to the end, because at this point we've delivered a lot of information in a short period of time. But we're going to go ahead on now to do some surgical observation through the video remote technology.
I was running a half marathon that I did not train properly for, and at some point during the running, it happened. Are we falling up? Oh. Okay. And it's just a torn labrum, right? Okay.
This is an arthroscopic and live surgical video with patient consent. I'm John Christoforetti, an orthopedic surgeon in Dallas-Fort Worth, Texas, and I'm demonstrating the knotless labral repair technique utilizing a knotless fixation device 2.4 millimeters in diameter. First, we attain the appropriate drill position on the acetabular rim, which has been pre-prepared. Following drilling of the blind socket for the anchor through the distal anterolateral accessory portal, the anchor is drilled here into this right hip at the 2 o'clock position. A wire is used to sound the bottom of the tunnel to ensure that there is no penetration of the deep acetabulum, and the cartilage of the articular surface of the acetabulum is viewed throughout drilling. Next, a half-pipe cannula is placed while we prepare for the opportunity to deploy the anchor. The next step, having drilled the socket for receipt of the knotless anchor, is to place a suture into the labrum tissue itself. The free suture is passed from the capsule or faraway side of the joint through into the articular side of the joint through the labrum. This labral base stitch is now created by piercing again the labrum and entering into the deep side of the joint, grasping the suture. As the suture is retrieved, it creates a capturing construct that leaves the labrum of the hip free to engage with the femoral head without concern for abrasive rubbing of the knots around the edge of the labrum, and maintains an excellent anatomy for repair. In the outside view, it can be seen that suture management is critical. First, we need to use our ring grasper in order to clear any debris or any tissue that has been snagged by the retriever on the way in, and making these tails available for passage through the eyelet of the knotless repair construct. At this point, the hole that has been pre-drilled now needs to be filled with the anchor, and the sutures themselves are used as a guide along the half-pipe cannula. We use a hemostat to control the tails of the sutures, and we want to angle our instrument towards the half-pipe cannula so that we can smoothly go down without getting into any soft tissue entrapment. Once we achieve the appropriate angle towards the bony socket, it's a filling of that socket while we watch the tension of the labrum to ensure that we don't evert or invert the tissue through over or under tensioning, respectively. Another tip viewed in the arthroscopic screen at this point is that the eyelet of the knotless anchor should be in a tangential direction to the sutures, and any twists should be removed so they can be evenly tensioned, and that can be done with a simple twisting motion. This will show as we reduce the labrum back using the sutures that bar of suture is capturing not only the base of the labrum but the articular surface that was damaged in this case. We seat the anchor appropriately and deploy the anchor, followed by trimming the tails for the knotless construct. We use an open cutter so that we can easily see and protect the tissue as we remove the sutures, and after trimming them, we can see the final 2 anchor knotless repair. At this point, a probe is brought into the joint to demonstrate the stability and the excellent reduction of this labral chondral tear from the rim of the socket back to its host bed. We have done a no capsulotomy, or what's called a periportal capsulotomy approach, and what we want to do at this point is use a dynamic examination of the hip that allows us to visualize the engagement of the repaired labrum with the femoral head through a functional range of motion. The distractor table is very helpful for this, and the assistants are also helpful to maintain a good atraumatic look at the head and the labrum, and we can lift with the probe as we move the hip through a functional range of motion, demonstrating a stable joint without any interfering knots or suture, and that is certainly the advantage of the knotless repair, and when tensioned appropriately, the perfect recreation of the suction seal of the hip as demonstrated in this video.
So here we see another indication for endoscopic surgery around the hip, and this is something that you may have experience with inside your athletes. We can see the bruising on the thigh of a complete hamstrings rupture, the tendons ripped off the bone. And in this case, what we're doing nowadays is taking an ultrasound machine, pictured in my left hand, and we're going to use that to safely navigate around the sciatic nerve, which lives deep and just next to the hamstring that's been ripped off. And we know that there are indications for repair here. We don't have the ability to repair when muscles tear from muscles, but when the tendon tears from the bone, we've developed a method where we're capable of using that ultrasound transducer to identify the place to go down. As you can see in the ultrasound image to the right, we can see the dark area where the bruising is, the bright white where the nervous tissue is, and then we can really keep our incisions safe, and we use what's called an endoscopic assisted repair. And this is just another application of modern surgery to the athlete's hip. Finally, we have gluteal tendon endoscopy, and this is when someone in the master's athlete class rips and gets that rotator cuff tear of the hip, and we're going to watch this repair video demonstrating that anchor being placed into the bony trochanter of the femur. We can see the loose torn edge of the tear of the abductor. That's the glute med and glute min. And we're watching this plastic anchor be deployed. This is an absorbable single anchor repair in this particular case. But what this is allowing us to do is through small incisions, access down to that torn abductor. And we're going to go ahead and repair this down. Now, we use a variety of grasping instruments, as you've seen in the previous case reports. We've looked at a runner's labrum. We've looked at just simple knotless labral repair. We've also looked at the endoscopic approach to the back of the hip, that hamstrings tear, and now we're looking at that lateral or outer hip. So hopefully this, for those of you that have persisted through the back end of the hour, is something that really gives you an understanding without having to make a whole day off of your time and coming and standing in the sterile operating room of really seeing what's going on inside athletic hip surgery. In the athlete's hip, we have new frontiers. We don't have various answers about the healing rates in different areas inside these endoscopic approaches that we may have in the labrum, but you can rest assured that we're going to have those into the years to come. The first of these repairs that I was able to personally perform was in 2009, and we've performed dozens of these repairs since. But again, as each time we look with research and outcomes, we're able to hone these outcomes and improve them. So I'll leave the audio for a moment while you continue to watch the remainder of the suture repair of the tendon of the abductor down to bone with secure knot tying and the gluteal repair endoscopically assisted of the tendon tear in the athlete's hip. And here we're trimming that final repair knot, and we'll do that one more time with the second suture, and we'll have completed our endoscopic repair, that rotator cuff repair of the hip. And the abductor repair has a different protocol following surgical repair than the labrum, as you might imagine. Well, there you have it. That's been quite a tour. We've gone from the office in our kinetics area through the whiteboard room. We've thrown in some traditional slides for you, and we've been inside the operating room working together to bring you through a tour. Hopefully this really gave you a nice taste of the cutting edge of the surgical side of athletic hip medicine. I certainly invite you to come join us for more learning into the future. And I want to thank again the SWATA course organizers and all of you for your kind attention.